Now, when you talk about psoriasis, see, I will give you a small brief and then we will move forward. Okay, you know that it is a papillosquamous disease. So it will have scaling. Yes. It will have papules. Yes. Maybe red, maybe purple. Psoriasis has red color papules. It can have plaques. Okay, because plaques was also present. So this is how you can imagine psoriasis. There are papules, there are plaques, they're red colored and there's scaling. Okay, a very rough overview. What happens is that it is basically a chronic T-cell mediated inflammatory disease. Okay, it's an autoimmune disease, your body is going crazy. So now it is a chronic, means it is not an acute problem, it can stay with the person forever. Psoriasis, once it develops, there is no treatment, we can only control it, but it can keep coming back. So there will be remissions and there will be exacerbations. Okay, it is an inflammatory disease that involves skin. But not just skin, it also involves other organs in the body. Okay, I know you still don't have a very good idea of what is psoriasis, but I will keep adding more and more to the picture that you have in your mind. So till now you have a picture of papules and plaques which are red in colored and there is scaling. Okay, uske upar a little deeper you went. So this is some chronic problem that the patient has, does not go away ever. You can have emissions, you can have remissions and exacerbations. Okay, and it will involve the skin and other organs as well. All right, now I've already told you that this is an autoimmune disease, but the antigen is unidentified. Okay, so there is something inside a person's body, but we have not been able to identify what is the real antigen for which all this autoimmunity is being targeted towards. Okay, the primary lesions I've already told you are papules and plaques. They are solid, circumscribed, raised lesions. And the secondary lesions, we have read primary and secondary lesions. Scales are always secondary lesions. So you have scaling. Okay. Now there's something called as etiopathogenesis. Why? What is the etiology and what is the pathogenesis? What is etiology? What do you mean by etiology? The various factors that can contribute to the disease. That is the etiology. What is pathogenesis? What really happened back end? The various factors, they cause the disease, but what happened? Like, factors did their work, but how were they able to give you the disease? That is pathogenesis. Okay, so etiopathogenesis of the disease. So see, I've told you that it is a T-cell mediated response. So you have Th cells, T helper cells involved, Th1, Th17 and Th22. Okay, and all these helper cells, they will release inflammatory cytokines. And those inflammatory cytokines will cause inflammation. Okay, so the cellular components is Th1, Th17 and Th22. Th1 is going to give you interleukin 1, TNF alpha and interferon gamma. Th17 will give you interleukin 17 and Th22 will give you interleukin 22. How to remember? 17 and 17 is fine. 22 and 22 is fine. Th1, interleukin 1 is fine. TNF alpha. See, alpha is also the first. A is the first, alpha is the first alphabet. Okay, so you can remember 1 में alpha भी आ गया, 1 में 1 भी आया. So Th1 so Th1 is going to be interleukin 1 and TNF alpha. That is fine. Just remember alpha के साथ another weird thing, gamma is going to come over here. This is how I used to remember. Okay, because this is not only important here, it is very, very important in microbiology also. So just remember Th1 is interleukin 1, which is fine. TNF alpha is fine. Just remember interferon gamma is also over here. Th17 is interleukin 17 and Th22 is interleukin 22. Okay, so these were the basic T cells that were involved and these were the cytokines they were producing, and now these cytokines are going to come and really make the skin bad. Okay, going deeper into etiopathogenesis, there is always a genetic component to psoriasis. Okay, HLA-CW6 will be a marker for early onset psoriasis. HLA-B27 is associated with psoriatic spondylitis, and there is a gene that is PSORS1 gene, SORS1 gene. Okay, this is a psoriatic susceptibility gene. So if you look at this gene in some person, there are 50% chances that this person now will soon become a psoriasis patient. Okay, so they have 50% risk of developing psoriasis if somebody has the SORS1 gene. All right. So that is genetic component. Remember, B27 anyway is something to do with spondylitis, so it is coming in psoriatic spondylitis also. Okay, CW6 is early onset psoriasis. Environmental factors, mein what do we have? We have drugs, infections, seasonal changes and substance abuse. What does this mean? See, there are certain drugs that can worsen your psoriasis. There are certain infections. You will come to know this was a question. This infection was actually a question this year in the FMGE exam. So there are certain infections that can lead to psoriasis. Seasonal changes. Usually summers are good for psoriatic patients and winters the things worsen. Okay, and even substance abuse like alcohol and smoking, they can worsen psoriasis. Okay, so etiopathogenesis may, we remember that there were T cells. T cells were kind of releasing the cytokines that was making the skin bad. There were other etiological factors. First was genetics. Certain genes were associated with psoriasis. Then there were certain environmental factors like some drugs, like some alcohol, smoking, seasonal changes, even stress, infections. All of this can lead to, and rather lead to worsening of psoriasis. Okay. Now you need to remember that there are certain drugs that can worsen pre-existing psoriasis. What are these? Beta blockers, non-steroidal anti-inflammatory drugs, chloroquines or anti-malarials in general, lithium, and sudden systemic steroid withdrawal, which is very, very important. Very important. This can be asked. So there are certain psoriatic conditions where we give steroids, but otherwise we usually avoid giving steroids to a psoriasis patient. Why? Because it's a very tricky game. It's a double-edged sword. It can help you, but it can also worsen the situation if you suddenly stop it. Okay? So we don't want to play that risky game, especially in our practice. So we avoid giving psoriasis patients oral steroids specifically. Okay? Now these were the drugs. What are the infections? Group A beta hemolytic streptococci. It can give rise to guttate psoriasis. This has been a question. This will be a question. Okay. Group A beta hemolytic streptococci can give rise to guttate psoriasis. I will explain this in detail in future, but for now just remember. Okay. And even HIV worsens psoriasis. Okay. So this is the etiopathogenesis of psoriasis. Now, I spoke about certain seasonal and environmental factors. So seasons, we have already discussed that it worsens during winters. Why? Because winters, your skin becomes very dry. And psoriasis and dry skin, they just don't go well together. Okay? So if you have dry skin, it will worsen psoriasis. Worsens psoriasis. And psoriasis worsens dry skin. Okay? So these people, they don't like winters. Alright, now there's something called as stress, which all of us have. But usually what happens in psoriatic patients, after a stressful period in their life, the lesions will suddenly become multiply in number, okay, and new lesions will keep coming up. It causes exacerbations. Alright, stress is very, very, very important for psoriatic patient. Sunlight, smoking, alcohol and pregnancy. These can also be associated with worsening of psoriasis. Okay. So just remember, there are certain factors that can worsen psoriasis. Now, so this was all the etiology. What is the pathogenesis? All of this, basically, what are they doing to cause the disease? Okay, so genetics we saw, drugs we saw, infections we saw, environmental factors we saw. What are they doing? They are activating the antigen presenting cells, which is the Langerhans cells. So they activate your antigen presenting cells, which is the Langerhans cells. Now these Langerhans cells, they will go to the regional lymph nodes. With what? With whatever they have picked up. Because they are antigen presenting cells. So they pick up an antigen and they go to the regional lymph nodes. We don't know what is that antigen they have picked up. Okay. Now, and in the lymph nodes, your T cells get activated, which we saw that it is a T cell mediated response. Okay. Th1, Th17 and even Th22. Alright. They will all release what? They will release TNF alpha, interferon gamma, interleukin 1, interleukin 17, interleukin 22. Okay, interleukin 1 is also released. All of this will cause the basal cells to divide and they will cause inflammation in the dermis. And you will have cellular proliferation, which is hyperkeratosis. I am sure you understood it till now. From here, you've not understood what happened. See, after your interleukins have been released, everything is happening in the skin. Okay, the lymph nodes were there. They activated your T cells. T cell released all of this. These interleukins will go to the basal keratinocytes. okay, and they will constantly stimulate the basal keratinocytes. We know that basal keratinocytes were the only ones that could divide, okay, and because of constant stimulation, they start dividing very, very quickly. All right, and they will have inflammation, but they will start dividing quickly. Because they're dividing very quickly now, you have a lot of cells over here. Okay, that is what is happening. You have cellular proliferation, which will be seen in the form of hyperkeratosis. Let me explain this further. There was a mistake by the Langerhans cells, initially antigen presenting cells. उन्होंने गलती करी कि वो कुछ भी उठा के ले आए. There was also a mistake by the lymph nodes that they did not see what they are bringing. They started the T cell mediated response. So there were two mistakes being made. Okay, lymph node, they send Th1, Th17 cells to the basal keratinocytes, which stimulates the basal keratinocytes to divide and replicate. Faster. Okay, all of this will cause hyperkeratosis and parakeratosis. What is hyperkeratosis? What is parakeratosis? We have already discussed this in dermatopathology. Hyperkeratosis is increase in the number of cells in the stratum corneum. Basically, stratum corneum, you have a lot of cells. What is parakeratosis? These cells are now nucleated. Okay, usually stratum corneum cells are enucleated. Parakeratosis, these cells have retained nuclei as well. We've already discussed this. Okay, the epidermal transit time. What was epidermal? We have also seen this also. That, see, basal cells say till the time you reach the corneum. This is the basal cell, this is the corneum. It used to take 28 days. Okay, from here to here, it used to take 28 days. Now you've stimulated the basal cells so much that it is only taking 3 to 5 days. 3 to 5 days, my cell from here went to the stratum corneum. Imagine how many cells are being produced. Okay, so in epidermis, you have hyperproliferation of keratinocytes, and in the dermis, you will have inflammation. So here in the epidermis, you have hyperproliferation of cells, and in the dermis, you have inflammation. Make sense? You have a brief idea of what happened. Two mistakes were made. Th cells were sent. They nudged the basal keratinocytes to divide. They divided so rapidly, your transit time decreased to 5 days. So a lot of cells are here, and there's a lot of inflammation in the dermis. Okay, so this is the etiopathogenesis of psoriasis. This is what is happening at the molecular level. What happened? There were a lot of factors that caused all of this problem. Now, so ये तो हुआ. ये in general, this happened in psoriasis. But you have different types of psoriasis also. What are they? You have chronic plaque psoriasis. You have guttate psoriasis. I just mentioned guttate psoriasis is because of group A beta hemolytic streptococci. Okay. You have inverse psoriasis. You have pustular psoriasis, erythrodermic psoriasis, nail psoriasis, and psoriatic arthritis. Okay. So there are 7 variants, 7 ways through which psoriasis can present to the body. Okay. Basal, same tha. The same thing is happening, but it can come in different parts of the body and in different presentations. That forms your types of psoriasis. Okay. Now, when we talk about chronic plaque psoriasis, this is psoriasis vulgaris. I've told you whenever vulgaris comes, that is the most common form. Okay. So this is the most common type of psoriasis. It is chronic. We know that psoriasis by itself is chronic. It is plaque, not papules. Now you have plaques. Look at this. You have plaque-like lesions all over the body. Okay, look at this. This, all of it, these are plaques. These are huge plaques. So this is your chronic plaque psoriasis. Till now, I've just told you what is psoriasis. I've not shown you the picture of psoriasis. I'll tell you why. Because the picture is different in different types of psoriasis. Okay, so this is what you most commonly see. If you look at this picture, what do you see? Let's just, I have nothing written over here. I'm just trying to explain you what you see over here. We see plaques. Chalo, theek hai. Plaques to ho gaya. What else? These are well-defined lesions. Well-defined. These are not vague lesions. You can see the boundary exactly where it is. So well-defined lesions. और क्या दिख रहा है यहाँ पे? You see something silvery. Right? These lesions are not skin colored. They are silvery. This is very important. That the lesions in psoriasis are usually silver in color. Why silver in color? Because all the cells that you have accumulated over here have now become compact and they look silver in color. And if you can appreciate a little, there's scaling also. Let me just reduce the pen size and show you. There's scaling here, there's scaling here, there's scaling here. Okay, so there is scaling. Okay. In general, this is what we can see from the picture. Ki plaques hai, they are well defined, they're silver, and they have a little bit of scaling here and there. This is the picture of chronic plaque psoriasis, which is psoriasis vulgaris, same name, like both the name are of the same disease. Okay, and this is the most common type of psoriasis. Now, clinical features we have already seen. Most of it we have seen. Let's just brush through it. Well-defined plaques and papules. Okay. Usually on the extensors, palms, soles and scalp. This is very important. So for every psoriasis now, you need to remember where it is happening. So chronic plaque psoriasis is usually on the extensors. This can be a question. Okay. Palm soles, so alright, but extensors is an important thing. Okay. Then the lesions are red, we saw. They can be salmon colored. Just a fancy way to see red. Okay. And erythematous. Basically red. Okay. But they're associated with scaling. And the scaling is silvery or micaceous scales. This is important. If you ask me two things, it is associated with scaling, that is one thing, and it is going to be on the extensors, the palm, soles and scalp, that is another thing. So these are two important things you need to know. Itching is present. Itching is a thing that is definitely seen in psoriasis, okay? Because of all the inflammation, all the inflammatory mediators that have come, they're going to release mediators for itching as well. And all that inflammation is going to give the patient restlessness, itching. Okay? So these are in general clinical features. Now, I've already told you that we're talking about chronic plaque psoriasis. Okay? So this will come on scalp. Look at this. On extensors. These are your extensors. Look at this. On the palms and on the soles. Okay. When it comes on the scalp, there's a characteristic thing that it exceeds more than 1 centimeter from the hair margin. Okay. So this is important. You need to know that it does not stop here. If I have a psoriatic lesion on the frontal part of my, forehead, it is not going to stop here. It is going to come 1 centimeter ahead. Okay. So till here, you might have a psoriatic lesion. In the back, you see there is 1 centimeter at least. It comes down from the place where the hair is stopping. So from the margin, it comes 1 centimeter out. What is this called as? So this is actually called as corona psoriatica. Okay. What does it mean? It means like a crown. Okay. So this is your chronic plaque psoriasis. Okay. Now, in psoriasis, again, there are certain named features, which is very important question. There's something called as Auspit sign. What happens over here? See, there's something called as Auspit sign. So see, what happens? Again, I'll give you a brief picture. We will read this in detail in the coming slides, but I'll just give you a small gist so that you understand this better. Okay. In the dermis, we have dermal papillas. We've seen that. We had a wavy line. Okay. Here, the one that is going up is dermal papilla. The one that was coming down were rete-ridges. So in the dermis, we have dermal papilla. And there we have blood vessels. Okay. And these blood vessels, they become tortuous. Okay. So if they were supposed to go like this, so this is the blood vessel I'm talking about, not the dermal papilla. This is the blood vessel. This was the blood vessel. Now it will become like this. Okay. So it becomes highly tortuous. Okay. This happens in the dermis in psoriasis. Alright. So now when you see a person who has psoriasis, you look at the lesion. You took a glass slide. Glass slide is a dermat's best friend. Kuch nahi samajhta, we just scrape a glass slide and it will give us a diagnosis also. Okay. So when you scrape the psoriatic lesion, that is called as a Gartrage test. So you cut this, it was mispronounced. So when you scrape the psoriatic lesion, okay, you saw the lesion, you started scraping it. Alright. This scraping motion has a name that is called as Gartrage test. Okay. So you kind of grattage it. Okay. what will you see? The scales were stuck. Now the scales start flying. There was something stuck. You started moving something on it. That stuck thing will start coming out. Okay. So there is accentuation of the silvery white scales. But you don't stop. You continue scraping. After the scraping over here, what you see is a shiny membrane. That is called as Bulkley's membrane. Okay. There's a shiny membrane that is called as Bulkley's membrane. You still don't stop. You keep scraping. You will have pinpoint bleeding. That pinpoint bleeding is called as Auspitz sign. So you were scraping over here. You saw a lot of silvery scales. They came out. There was a shiny membrane left behind on the lesion. If you kept scraping, you see bleeding over here. Okay. You will have pinpoint bleeding like this. Okay. So that is called as your Auspitz sign. What you did? You did a grattage test. Okay. You took a glass slide, you kept scraping till you see bleeding. Why was bleeding so easy on this skin? Because the dermal vessels, they have become tortuous and they've come very high up. So the minute you irritate them, they start bleeding. Okay. This is your Auspitz sign. This is a very important question. You need to know this. You kept doing the grattage test. You first saw silvery membrane that was called as Bulkley's membrane. You still kept doing, you saw pinpoint bleeding spots. This is your Auspitz sign. Okay. Now, there's something called as worn-off ring. What is a worn-off ring? See, it is a ring of hypopigmentation that surrounds the lesion of psoriasis. This is usually seen in the healing lesions of psoriasis, and it is because of altering in the levels of PGE2. But this is also a named thing that you see in psoriasis, a worn-off ring. So suppose this is the lesion of psoriasis. It has become healed, pretty healed. Okay, that is why you don't have that silvery scaling over here or anything. But surrounding that, you see a rim of hypopigmentation. See this, look at this, look at this. You see, if you look from far away, you will see these rims of hypopigmentation in the healing lesion of psoriasis. These are called as worn-off's ring, and it is because of a problem in PGE2. Like there's an alteration in PGE2 levels because of which you have this hypopigmentation. Okay, so we saw Auspitz, we saw worn-off. Now, there's something called as Cobner's. What is Cobner's? It is called as isomorphic phenomena. Okay, isomorphic means, iso means similar and morphic means morphology. So, similar morphology is being repeated. Okay, appearance of morphologically similar lesions along the line of trauma over the skin. And what does it indicate? It indicates that the disease is active. Disease खुद को replicate कर पा रही है. Only then along the line of trauma you will have similar lesions, right? If the disease was not active, you would not have newer lesions suddenly appearing. Okay, so that is your Cobner's. What happens is, if you have a psoriatic lesion and you scratch it, so wherever you caused the trauma, you have new lesions coming there. That is Cobner's. That is also true Cobner's. I think we've seen the true Cobner's, the pseudo Cobner's. Pseudo Cobner's we've seen in viral infections in molluscum contagiosum. You are spreading the virus, so new lesions will come. So that is pseudo Cobner's. Here you're not spreading anything. You are just causing trauma and the disease is taking the path. That is true Cobner's. You have isomorphic lesions along the line of trauma. Okay. What does it indicate? It indicates that disease is active. You need good medication for this patient. The disease is full-fledged, working, full-time. Okay. So that is your Cobner's phenomena. Okay. Now we will discuss it here only. You have true Cobner's, you have pseudo Cobner's, and you have rare causes of Cobner's. What is true Cobner's? It is because of immunity. So it is seen in psoriasis. It is also seen in lichen planus and vitiligo, which we will discuss both of these. But it is seen in psoriasis. What is pseudo Cobner's? Because of virus you are auto-inoculating the virus. So that is seen in molluscum contagiosum and also seen in warts. Okay, and there are rare causes of Cobner's. You may not see Cobner's here. Here you will definitely see Cobner's if the disease is active in true ones. But rare causes may you have Darius, Haley, erythema multiforme, Kaposi sarcoma, and lichen sclerosis. Okay, so here Cobner's may not be present. Rare causes are not that important, but true and pseudo Cobner's are very important. Pseudo Cobner's may virus, you were inoculating it in other places, and in true, the immunity is taking care of the disease. It's spreading the disease everywhere. Okay, psoriasis, lichen planus, vitiligo. Vitiligo is also very important for Cobner's. All right. So now these were all the things that you need to remember about chronic plaque psoriasis. Okay, everything you need to know about chronic plaque psoriasis. Now we move on to a different type of psoriasis, that is guttate psoriasis. This was a question this year, might be a question next year also, very common question. Okay, so guttate psoriasis mein firstly in the question they will say it is a child basically. Okay, so it is seen in children. Okay, that child will have a history of sore throat, that is pharyngitis or ear infection. So child has an infection. That infection was caused by group A hemolytic streptococci. Group A beta hemolytic streptococci. So what happened? That streptococci came, gave you a sore throat or an ear infection. Okay, uska kaam yahi tak tha. Your immunity went crazy again. All right, it is associated with HLA-CW6. Okay, your immunity went crazy and it caused psoriasis in the rest of the body. All right, but because it is happening due to a transient problem, that is a group A beta hemolytic streptococci, which was the antigen over here. When the antigen goes away, your immunity will calm down. So this is not a chronic psoriasis. Okay, this is limiting. It will be a very limiting episode of psoriasis that you will see. Okay, how do you treat it? You take out that beta hemolytic streptococci from the body. You treat the infection with antibiotics. So this is one psoriasis that will not even require anti-psoriatic treatment. You treat the infection, immunity will calm down, you will not have psoriasis. Okay, how does it look like? This is how it looks like. Usually seen on the trunk. Okay, so see, you see these small lesions, but they have scaling and they have silvery part. Scaling. Okay, silvery lesion. All right. So this is what you see in guttate psoriasis. Now, when you see guttate, it actually means raindrop. Okay, don't you think these lesions look like a raindrop lesion? Just look at this. Like raindrops have just fallen over here. Okay, so guttate means raindrops and multiple small guttate, raindrop or coin-shaped lesions. This is important. So these are coin-shaped. The tiny lesions of multiple, usually on the trunk, on the chest, can be present on the hands in a child who has a history of sore throat or ear infection, and they give you this image. Think of guttate psoriasis. Okay, situs, trunk, I've already mentioned. Okay, so this was your guttate psoriasis. Everything that you need to know to solve a question is given in these two slides. What you need to remember? You need to remember that it is a child. The child has had pharyngitis or ear infection caused by group A beta hemolytic streptococci. HLA-CW6, not that important. Treatment, antibiotics, no problem. And these are coin-shaped lesions on the trunk. This is the image. This image was asked this year. Okay, so this is your guttate psoriasis. All right.